The root of an eyelash looks like this under a microscope, and beside it is Demodex follicularum, one of the 2 species of mites that mostly live in hair follicles and oil glands. These mites are associated with eyelid margin diseases such as Demodex Blepharitis and Meibomian gland dysfunction. The eyelid margin has long been an underestimated structure as far as ocular surface health and dry eye are concerned. Not anymore. Thanks to a consensus group from the Intrepid Eye Society that put together an eyelid margin health approach in addressing both Demodex Blepharitis and MGD, the faculty's consensus on eyelid margin health, published in this Cookie Magazine supplement, hopes to raise awareness and promote increased frequency of screening for improved patient outcomes.
Continuing the education on eyelid margin health, I'm Cecelia Koetting, and we're currently filming one of 4 educational videos on the complement, the consensus statement on Demodex Blepharitis and Meibomian gland dysfunction.
It's important to have 2 different trees for this because they're 2 different conditions. They interact, and they're all very multifactorial. There's a lot of moving parts here, but they're different things, and we want to think of them as separate conditions that interact, because I think it just makes makes more sense.
So we've got 2 decision trees, one that's on Demodex Blepharitis, and the first part, do they have scurf or do they have collarettes, right? Because we're starting to try to decide if this patient has just bacterial or if they have some kind of Demodex component to it, so then we know where to go from there with treatment. If our patient has scurf, we're going to be more geared towards treatment with just cleaning and potential antibacterials if needed, versus our Demodex patient, where we're then going to look at treatments for that, which may include lotilaner, also cleaning, but it may be more, for me, tea tree oil based or okra based. And then off of that, we have this lovely little rosacea tree. And if they have rosacea, we might be adding in IPL. You may still do that even if they don't have rosacea.
So 2 big parts to that, I agree. Does the patient have blepharitis? Is there inflammation in the lids and lashes? I agree 100%. And the differentiation between those collarettes for Demodex blepharitis and more scurf, like you're referring to, scurf being more of that flaky on the lashes, there's stuff there.
Yes.
But the stuff isn't that perfect cylindrical collar at the base of the lashes, signaling an infestation of Demodex. So 2 big components. Part of our dysbiosis that we find in blepharitis is, staph especially, but bacterial components that I agree 100%. Antibiotics, cleaning with antimicrobials like hypochlorous acid is one of my favorite.
Great one, yeah, absolutely.
Versus treating Demodex with lotilaner and then, management long-term to trying to keep things cleaned up after that.
And you can have both. Can't forget that. What do the Demodex eat? They eat the scurf, they eat the bacteria, So
it's a spectrum of disease, and you're trying to pick out what's the main offenders and flow through that, hitting the high points first, and then always reassessing your patients once they're back with you for follow-up. The nice thing about this tree is it helps steer the ship. It kind of breaks the diagnosis down into separate groups, and then it helps you steer the treatment because of that flow path, if you will, of decision-making, separating out things. And like we talked about, yes, you can have multiple things, but it's best to start with one and then move forward from there.
The key things that kind of kick off going into DB decision tree, or talking about our Demodex. One, yes, patient symptoms are a big part of this if they're complaining about itching, especially all along the lash line versus just in the corners. If patients are talking about the eyelids being red, their lashes being brittle, those are some things that are kind of key to me. But at the end of the day, even if there's no complaints and I see collarettes, that's 100% right there. We're going into the Demodex right there.
Yep, and once you see those collarettes, it's a great time to reassess the patient's symptoms.
Yes, absolutely.
To say, hey, are you picking at your lashes? Do you notice that your eyelids are red? Have you noticed that your lashes are shorter or falling out more? What sort of symptoms might this patient be complaining of associated with Demodex blepharitis that they might not even associate with blepharitis?
Yeah. So with the decision tree, looking at the guidance as far as to treatments, it does help us with breaking it down into two different groups in office as well as kind of other therapeutics prescription that we might do. But honestly, they need to work together. And sometimes it has to do with what we have in office and maybe what we've done before. But I mean, first step is really good hygiene and keeping the area clean. And that's, again, as you mentioned, long-term, something for these patients, but then coupling that with a very poignant treatment specifically for Demodex blepharitis, which is lotilaner. And then also adding in IPL, which may or may not be something that is an option for some practitioners.
Yeah, I always like to clean up the blepharitis first. Kind of go from the outside in, clean up the blepharitis first, and moving backwards, start treating your ocular rosacea with maybe pharmaceuticals, but also in-office treatments. I know we know there's so many options for rosacea, and ocular rosacea is probably underdiagnosed, undertreated, and a big part of this disease state.
And I think it's a really good thing to mention also, don't forget about lateral referrals. If you don't have the option to do an IPL, blepharoexfoliation, any of these other procedures in office, you've got friends, other optometrists that are down the road that maybe can do that, as well as if you're talking about treatment of rosacea, dermatology.
When distinguishing and diagnosing meibomian gland dysfunction, there's two big things that I like to think about: obstruction and inflammation. And a lot of times you'll have one more than the other, and that's the primary go-to for my treatments for meibomian gland disease. If I'm seeing a lot of obstruction, I want to treat that first. Those usually respond best to thermal treatments, and also IPL has some role there as well. If I'm seeing a lot of inflammation around the glands, and that can sometimes present itself with more symptoms, tenderness in the lids, tenderness with expression, then I'm going to want to manage that inflammation. IPL does a great job of managing inflammation as well as some of our pharmaceutical options.
Yeah, and also that can indicate infection as well a little bit, which is definitely where if you have an infection, we want to make sure that we use use an antibiotic, whether that be doxycycline, or I personally am a fan of oral azithromycin using a Z-Pak. There's some benefits both directions, but as far as getting the infection under control while also addressing everything that Jake has mentioned as well.
Yes, these inflamed glands are at risk for infection, right? We see preseptal cellulitis and that spectrum of disease.
Absolutely. So the decision tree kind of walks us through the different levels of damage to the meibomian glands, and so then we're able to start to think about what's the most appropriate treatment. I think no matter what, all patients in a perfect world would be doing warm compresses, lid hygiene, some nutraceuticals, things to promote meibomian gland function and health. I talk about them like teeth. Once they're gone, we can't get them back. We don't have dentures for our meibomian glands, unfortunately. So we really want to foster keeping them as healthy as we possibly can. And then moving into other treatments beyond that, and really utilizing meibography, or even if you don't have a meibographer, Gland, you can look at them with transillumination and expression. You have to look at the structure and the function so that you can make a better decision as to when you're going to move on to that next level of treatment.
When you're seeing that patient, right, it's a stepwise approach, right? You start simple, and then you're going to bring it up to their level of disease, to the necessity that this patient's presenting you with.
So for me, the decision of when I move into having a discussion with my patient about whether it be thermal expression, IPL, meibomian gland probing, things like that, really has to do both, again, looking at the morphology of the glands. How am I starting to see atrophy? Am I seeing that we've got loss of gland structure? As well as looking at the function of the glands. The easiest thing, I think, is when the glands are all there and I'm just seeing that the expression is not healthy. It's difficult to express, minimal expression, or caseous, turbid, right?
Form is good, but function is lacking.
Yes, and those are the ones I'm excited about because I can really help them, especially IPL, I find, in expression in those patients works very, very well. It's when we get to the point where we've got a lot of atrophy and I'm trying to save those poor struggling last glands that I do tend to turn a little bit more aggressive, continuing still with the IPL, but we may be doing it on a more frequent basis. I might be doing expression, and occasionally I do Meibomian gland probing in those patients.
Patients are individuals, so we really do need to individualize their medicine. We need to individualize their treatment. So not everyone is going to be able to do every treatment. No, not everyone's going to be able to maybe afford every treatment. Some people can't put drops in. Some people have phobias and claustrophobic things where they're not going to want procedures done on their face. So we really need to meet our patient halfway. Yeah. This is personalized medicine. This is personalized eye care. So we need to tailor everything. And it's okay to go outside these decision trees. Yeah. It's okay to try different things, try new things. Not every decision is going to be perfect for every patient.
Guidelines are just that. They're guidelines. They are not one size fits everyone. Yep.
Decision trees sometimes help you think through things. They help you decide, where should I go next? What's the lowest hanging fruit here? And sometimes just staying on target and staying within your guardrails can really help you steer the decision tree and hit those low hanging fruits first. And it's amazing sometimes how much improvement your patients will see by just doing some simple things.
Yeah, absolutely, I would agree.
Some great examples of low-hanging fruit and easy decision-making is, I think of my Demodex Blepharitis patients.
Oh,
you
absolutely,
see those
yes.
collarettes, you know what you're up against, you know that's prevalent, you know it's part of the problem. Take that variable out, treat that Demodex Blepharitis, and then reevaluate the patient. I think that's just such an easy diagnosis to make.
If I see collarettes, I hate to say it, but it's a little autopilot at this point that I'm like, yep, okay, I know what we're gonna talk about. Let's talk about lotilaner, we're gonna talk about cleaning, we're gonna talk about warm compresses, and boom, let's go. We've got decision trees we've put together for ourselves. It may be about other things. And this just provides kind of, again, a little bit of guardrails, guideline of something that maybe some of our colleagues aren't feeling as comfortable with, especially as new treatments and options are coming around. So it might be something that even keep as a reference on your desktop, right? That you're like, oh, yes, let's think about where we're going to go with this, and it can help speed up the process, actually, I think, at the end of the day, for making some of these decisions for these patients.
Yeah, I agree. Just like everything, it might take a couple extra seconds or pull that out and reference that step out at the beginning, but once you build those habits, this is going to become routine. Once you learn the habits of A, then B, then C, it becomes second nature. And as we have these expanding and new technologies and treatments, we need to integrate those. So sometimes it is time to step back, reevaluate our flow, our workflow, and our procedures so we can reinvent those so we can become more efficient in the future.
The consensus statement outlines the best practices for managing eyelid margin health as a result of surveying expert faculty, the Intrepid Eye Society. These videos add to the information found in the supplement, previously published by Cookie and available to read and download at the link in the caption. We hope you enjoyed our colleagues continuing to share their expertise on this topic. Follow along with the Fundingsland Group to be alerted when they are available.